Salam and hello everyone. Welcome to WinFocus Virtual Congress 2024. Thank you for joining us in this year's even more exciting event. My name is Julina, and co-chairing this Congress are my friends Francesco Corradi, Hamid Shakohi, Chris Fox, Magali Gothi, and Dave Tank. We present to you 2 full days of point-of-care ultrasound programs comprising of 3 tracks that will surely blow your mind. There's something for everyone, from students to consultants, novice to experts, pediatrics to adults, current practice to future expectations. And don't forget to tune in to the highlights of the Congress, which are the debate sessions showcasing panels of experts, and you become the jury. And now I will let my colleagues to furnish you with what's in store. Over to you guys.
Hello, everybody. I'm Francesco Corradi from the University of Pisa, and I'm so excited to introduce track 1 section that is focused on the transformative role of point-of-care ultrasound in the current medical setting, including AI application. So don't miss ultrasound management of ventilation, focus for sepsis and infections, cutting-edge technology for the future of ultrasonography, the outstanding heart failure joint section with the European Society of Cardiology Acute Cardiovascular Care, deep dive into the abdominal point-of-care ultrasonography, and 2 Spanish section. Os espero a todos. Hasta pronto y no te lo pierdas.
Hello, everyone. I'm Hamid Shakohi. I am one of the faculty at Massachusetts General Hospital in Boston, Massachusetts. I'm honored to share a stage with my talented co-chairs here, and welcome to the WinFocus 2024. In the next 2 days, you are going to see a wide range of the topics for the resuscitation, critical care. Every group of the specialty, actually, they have some share in this presentation, from musculoskeletal in sport medicine to rheumatology to nerve block, and the deep dive into the topics of the article of the years that actually you can see the influential articles that have been selected for a presentation. And we are so excited to just see this variety of the speaker, variety of the topics, and variety of the specialists that they are participating in these 2 days of the presentation. Thank you very much, and welcome to WinFocus.
Hello, everyone. I'm Magali Gauthier, a pediatric emergency doctor from Geneva in Switzerland, co-head of a pediatric department in Hôpital de la Tour. And it's a great pleasure to be co-sharing the pediatric session with Dave Tang. We're going to do a little tour of the world, starting in Oceania and then finishing in Americas. And all experts from around the world will share with us their experience in point-of-care ultrasound. We're really very excited about that. Please stay with us and enjoy.
Hello, everyone. Thanks for joining the WinFocus group. It's been an honor to work with these fantastic people, and Magali has put together a wonderful program for your not only learning, but you will get education and insight into cutting edge and point-of-care ultrasound for pediatrics, and be exposed to just some fantastic experts in the field. It's been an honor to work with everyone, and I'm excited for you to take our journey through pediatrics and point-of-care ultrasound. Can't wait to see you. Thanks for joining us.
And so finally, this year we have a track specifically on ultrasound in medical education that includes curriculum planning, teaching techniques, and what students can do with what they learn. We are all here to grow and learn. I encourage you to engage fully in the sessions and discussions. Do ask questions, challenge assumptions, and share your insights with the rest of us. And now let the Congress begin, and we leave you with the amazing speakers for WinFocus Congress. Thank you.
All right, here we are, 2024 WinFocus World Congress. This is so exciting. We have 2 days, 3 tracks, 4 hours of Spanish, 4 hours of Portuguese, we have abstracts, 3 of which will be presented during the course of the Congress because they're so exceptional, but all of them are very interesting, and you must go to the website and take a look at them because they definitely weren't the time. Thank you so much for this Congress. First of all, to our chairs, Jelena, who's been the leader of the whole process, with Francesco Corradi, who you see, Hamid Shukui, Chris Fox, Dave Tang, Nur Al Jabut. I hope I pronounced that right. But amazing group of chairs have brought this thing to the fore. Thank you to our secretariat, Christina Rekesens, Davide Neri. We've been actually working like crazy the whole way through. We also have Kim Fuster and Marina Guzman, who've been coordinating so much of this work that's gone on. Thank you all to the speakers, who've just an incredible group of people from around the world. Thanks for giving your time, your expertise to make this Congress the fantastic thing that it is. Thank you to the registrants. Many of you are WinFocus members. Great. I welcome you back to your Congress. And I'm very happy to say you're able to attend this completely for free. And for those of you who are not WinFocus members, please think about joining us so that you can be here for free next year. WinFocus is an organization dedicated to sonology and practitioners of point-of-care ultrasound. We work through science, we work through community, we work through leadership, and this Congress is a high point of our year every year because we're able to really show our chops in all 3 of these areas: leadership, science, and community. I hope that the next 2 days are exciting and rewarding for you, and leave you completely charged in the thing that all of us love to do in our care of patients, ultrasonography. With that, let's get on with the Congress. I'm going to pass over to Dr. Corradi to present our keynote speaker for the day.
Hello to everybody. My name is Francesco Corradi, co-chair of the WinFocus World Congress 2024, and I'm so excited to introduce the first keynote address on Bahrain ultrasonography, led by Arita Bertuetti from the University of Brescia, Italy. She is a young colleague, a senior researcher, and an established and worldwide recognized leader on the topic. So enjoy, and Arita, the floor is yours.
Hello, everyone. My name is Rita Bertuetti. I'm a consultant in neurointensive care in Brescia at the University Hospital. I've been given this tough task of a keynote presentation about brain ultrasound. So I hope to provide you with some overview of the main clinical application by exploiting a basic skills. Okay. So here it is. I have nothing to declare. So why ultrasound in the brain? So TCCD and brain ultrasound are now well-established diagnostic methods. So they allow bedside non-invasive imaging of intracranial structures, vascular, but also of the brain parenchyma. But what I would like you to understand from my presentation is that brain ultrasound and TCD and TCCD are point of care ultrasounds. So they are not confined anymore in the neurosonology labs, but they should be used by emergency doctors and intensivists in order to answer specific questions. So we can adapt the kind of examination of insonation that we perform to answer different questions. So in different clinical settings. So not only in a neuro ICU, but in general anesthesia patient, cardiac surgery, ECMO patient, general ICU, emergency department. And on the right of the screen, we see all the things that we can do with brain ultrasound. We can estimate cerebral perfusion pressure and intracranial pressure, assess cerebral blood flow. We can assess the presence of bleeding and masses, hydrocephalus, midline shift, vasospasm, cerebral embolism, cerebral autoregulation, and cerebral circulatory arrest. We need to keep in mind that despite the call that is taking our patient to the emergency department or to ICU or under anesthesia or whatever, the brain is part of the outcome of our patient. So we need to monitor it and don't forget about it. So some of those items are not so easy to achieve. It takes a long time, some skills and advanced also software for monitoring specific like autoregulation, for example. But there are other things that are very useful in everyday clinical practice, and we can achieve by with a basic skills that we can practice more. And those are estimation of ICP and CPP, assessment of CBF, assessment of the midline shift, and vasospasm. And in my presentation, I would like to focus on those items as basic skills that we can achieve. Before we start examination, we need to remember to monitor ABP and heart rate during the procedure and position ourselves behind or at the side of the patient's head. And another thing is that very small movements make a lot of difference in this kind of examination. So it is a good habit to hold our wrist against something like the pillow of the patient or something, just to stay firmer. So in brain ultrasound, we use the cardio probe. So and instead the black one is the blind TCD probe. On the right of the screen, we see a linear probe, which is used for the insonation of the optic nerve sheath. In the middle, instead, we see a complete different setting. So we placed a helmet for blind TCD, continuous monitoring in a patient in general anesthesia, undertaking aortic arch surgery, so very delicate surgery. And we try to monitor CBF, cerebral embolism, the quality of flow during this particular surgery. So having said this, the bone is a main obstacle for ultrasound propagation. So for insonating the brain, we need to exploit anatomical windows. There are 4 main windows for the insonation of the brain. So we need to keep in mind the acronym motor, the mandibular, the occipital, the temporal, and the orbital. Well, for a basic insonation, I think that we should focus on practicing temporal window and the orbital window for the insonation of the optic nerve sheath. So I will go through these 2 windows in my presentation, trying to show you what is physiological and what kind of assessment we can do through those 2 windows. So this is another picture of the type of what we can see from those windows, especially vessels in these specific pictures. And those 2 following tables are a nice summary of the anatomical landmarks of the types of vessels that we can actually insonate through all the windows. And the types of planes that are possible to achieve through the different windows. So going to the transtemporal window, we place our probe with the pointer directed toward the eye of the patient, above the zygomatic arch, where the temporal bone becomes thinner, somewhere between the tragus and the eye of the patient. And once we have found our external landmark, what do we expect to see? Okay. So if we place our probe perpendicularly to the skin of the patient, we might be able to insonate the brain on the mesencephalic plane, so the brainstem plane. If we tilt the probe slightly 10 degrees in a cranial direction, we encounter the third ventricle plane, where we see the third ventricle is displayed as a double hyperechogenic line. And by tilting the plane furthermore, we might be able to see the ventricular plane. So for a more specific images. Here it is. So this is a brainstem plane. So our anatomical landmarks are the contralateral bone here. This is the sphenoid wing, and this is the brainstem. The brainstem is something that we always want to see when we start our insonation. So both the sphenoid wing, the brainstem, and the contralateral bone are let's say granitic landmark for the beginners. So the brainstem is this heart shape, slightly hypoechogenic heart shape picture. And here more, if we tilt the probe slightly superiorly, 10 degrees, we are able to see the third ventricle. So here again, this is sphenoid wing, the contralateral bone. We tilt the probe and we see this double line here. This is the third ventricle, and those two hypoechogenic structures here are the thalami. So if we think that the third ventricle is really in the middle of the brain, we can keep this as a reference point for the measurement of the shift in pathological situation. So we can take the measure from the bone plate to the third ventricle from one side and then to the other side, and then repeat the same measurement on the opposite side in order to check the planes of insonation. So once we have got our measurements, we make the difference and divide by 2, and we get the midline shift. And how does it behave when compared to the gold standard, which is the CT scan, of course, where there is a positive correlation between the two techniques with a tendency to underestimate the shift with the ultrasound. So in this paper, Mutual found that the best cutoff for identifying a significant midline shift using the ultrasound is 0.35. So he found the best ROC curve by using this cutoff. So this is a useful technique in the emergency situation, but also if we want to follow up our patient, we know that there is a shift. We may compare the ultrasound insonation with the CT and then follow up our patient for changes, for example. And again, always from the transtemporal window, this is the sphenoid wing, the contralateral bone, and this hyperechogenic thing here is a temporal bleed. This is a subdural, so this hyperechogenic slice attached to the contralateral bone, and this is a small epidural, and this is the evolution of the small epidural. A few hours later, this is the brainstem. And this is how it looks like a subarachnoid hemorrhage. We see hyperechogenicity around the brainstem in the basal systems. And what happens if we want to see the vessels? We put the color on. This is what we might see. This is the circle of Willis, okay? Just rotated 90 degrees from what we have learned in the medical school. So this is a circle of Willis. And what we can see here is the ipsilateral MCA, the ACA, the contralateral MCA. Those are the PCA that surrounds the midbrain, okay? So after having visualized our vessels, we want to measure the flow velocity. So the spectral analysis of the flow velocities can give us a lot of information. So MCA is the easiest vessel to insonate. It's there. It's very perpendicular to the probe, and it is used as a pressure transducer of the brain, as it supplies 2/3 of the CBF to the upper brain. And by the spectral analysis, the machine returns us with a systolic peak velocity, a mean velocity, and an end-systolic flow velocity. As intensivists are very much fond of end-systolic velocities and mean velocities, and later on I will explain why. The analysis of flow velocities have been studied in many situations. Well, first of all, and the main application of analysis of the flow velocities is for the assessment and monitor of cerebral vasospasm. Also, guidelines suggest to use transcranial Doppler for monitoring the development of arterial vasospasm. What happens is that the narrowing of the vessels produces a drop in the pressure at the two ends of the stenotic tract. And so in order to maintain the CBF, we see an increase in the flow velocities in the stenotic tract. So the relation between the diameter of the vessel and the flow velocity is quite linear as long as the flow is maintained. If there is a drop in the flow, so when the flow and if the flow is not maintained anymore, then this correlation between the diameter of the vessel and the flow velocity is not so easy and so reliable. And furthermore, from this graph, this is a seminal paper, quite old one by Hazlitt, which is the father of the TCD. We see that there is also a correlation between the flow velocities and the ABP. So we always need to keep in mind that what we see, the velocity that we insonate, are very related to the blood pressure the patient is at in the moment we do the examination. But anyway, the increase in flow velocities can be seen not only in vasospasm and stenosis of the vessels, but also in a situation of hyperemia. In order to differentiate a hyperemic state from a vasospastic state, which need two completely different treatment, and here is a table with the cutoff. So we speak of increased flow velocities in the MCA when the mean flow velocity is above 120 centimeters a second. Okay, and we see that as the velocity grows, then there is an increase in the severity of the vasospasm. And as I was saying, this is sensitivity and specificity of the technique for vasospasm. We see that MCA is the most studied vessel, and here we see that the sensitivity is not, it's quite variable, let's say so, with a very good positive predictive value, but not so great negative predictive value. So when this is why, because when the flow is not maintained anymore through the stenotic tract, we may not appreciate an increase in the flow velocity. But again, here we see that there is also another thing that we need to take in consideration when we speak of vasospasm is the angle correction. So in the old papers, they used the blind TCD for assessing the flow velocities, and they didn't allow angle correction. If we apply angle correction, the sensitivity of the technique greatly increased. What I was saying earlier is that we need to differentiate a situation in which the velocity is increased because of vasospasm from those because of hyperemia. And to do that, we can perform the Lindegar ratio. So whenever we have an increased flow velocity in our MCA, we also insonate the carotid in the submandibular window, so the internal carotid, and we make the ratio between the two mean flow velocities. And if this ratio is above 3, in that situation, we speak of vasospasm. Otherwise, we speak of hyperemic state. So moving on to the next application, always insonating the vessels, and specifically the MCA, we speak of quality of CPF and assessment of CPP and ICP. So this is a nice picture of a normal waveform in our MCA. So we see there is a systolic peak, a dichrotic notch, and a quite smooth decrease to the end-systolic phase. And this is a patient with a normal ICP. Let's see what happens when the ICP of our patient raises. So increasing the ICP, and there is a change in the waveform of the of our MCA. So we see that the dichrotic notch disappears. There is a steep fall from the systolic phase to the diastolic phase, and the diastolic flow velocity decreases. Okay, and this is the evolution of a progressive decrease in CPP and a progressive increase in ICP. So let's see here on the left, this is a normal pattern. This is an increased ICP, and we furtherly move on. This is increase in ICP and a further decrease in CPP. We see that there is a change in the wave. So it becomes very narrow. The diastolic flow velocity decreases a lot. Then the diastolic phase totally disappears, and we appreciate only the systolic peaks. And then we move to this situation of reverberating flow, so biphasic and oscillating flow, okay, which is due by the fact that the blood arises in the carotid and then goes back because there is an increased resistance to the flow because of raised ICP. So this is just systolic spikes, so very narrow and small, and a situation of no flow. And these three situations, these four situations here, are patterns of cerebral circulatory arrest, so a no way back situation in most cases. Okay, so in order to assess ICP and CPP, we need to follow the waves. So observe how the wave it is, measure the flow velocities. So as I said, I said something earlier, the first velocity to be affected in situation of low CPP or raised ICP is the diastolic flow. The velocity. So the vessels inside the brain, they behave more like in a resistor of Stark. So when there is an increase in the resistance to the flow, the diastolic phase is mainly affected with a reduction in that component, while the systolic peak is maintained. This produces an increase in the pulsatility index. The pulsatility index is an index that is given by most of the machines. And so a normal value is below 1.2. The PI has been studied and investigated in many studies in order to assess its accuracy and goodness for non-invasive assessment of ICP. So there is an increase in the API when the ICP is high and the CPP is low, but it's not so good for discriminating critical values for the treatment. I mean that if I have a PI of 1.4, I'm not sure that the patient has got 25 of ICP. So it's not good for differentiating between 18 and 24 of ICP. So for sure, we will see an increase in the PI when the ICP is high or the CPP is low, but it's not good for discriminating critical situation for the treatment. So the group of study in Cambridge in the late 90s analyzed a lot of patients with a traumatic brain injury that were monitored invasively, and also they did a lot of sessions with continuous DCD. So they analyzed the flow velocities pattern of the three components, so mean, diastolic, and systolic, and they found actually that the diastolic flow velocity is the first to be affected. So by analyzing all those data, they came out with this formula for non-invasive assessment of CPP, from which we can derive a non-invasive ICP. The formula is quite good for the assessment of CPP, even though the error for the ICP is quite significant. We speak ICP is a small number, so so an error of 5 is very significant on that number. But the formula still is very useful for monitoring the changes in the ICP in our patient. Another point of view of the application of this formula has come from the IMPRESSIT study, which is a multi-center study in which they investigated the negative predictive value of this formula. And from this study, we have learned that if we put an ICP cutoff threshold of 25 with invasive method, the formula is very good at excluding intracranial hypertension. So it's something very useful in emergency situations. So we want to make sure that our patient hasn't got a very elevated value of ICP. We perform this study, we calculate the CPP and ICP, and I mean, we can get a lot of information from this. One thing to say that this formula is highly affected by the blood pressure levels of our patients. So if the patient has got low ABP, in that case, it will underestimate ICP, and because the CPP will be also low. Okay, and coming to the last part of my presentation, always in terms of ICP assessment, a very elegant method is the insonation of the optic nerve sheath. So the sheath enclosing the optic nerve is in direct continuity with the dura mater. So whenever there is and CSF is contained in this in the subarachnoid space. Okay, so the nerve is surrounded by dura mater, and whenever there is an increase in the ICP, the CSF pressure will increase, and so this increase in the CSF pressure will stretch the membranes of the sheath. Okay, by determining an increase in the diameter of the sheath. Okay, we use a linear probe. We need to lower down the mechanical power of the machine in order to prevent any damage to the retina. And here is what we can see. Okay, this is our eyelid, this is the iris, the vitreous body, the optic nerve disc, and this is the optic nerve. Okay, so the optic nerve is a very hypoechogenic structure, and around the nerve we see two membranes. Okay, that are less hypoechogenic. Okay, here is more visible. This is the sheath of the nerve, and it is the sheath must be measured in its retrobulbar part, so 3 millimeters behind the optical disc. This is the place where we take the measurement, okay? And here is again what I was showing earlier. What about the cutoffs? In literature, there is still some confusion, okay? So we know that below 5 millimeters, it means that there is no raised ICP. Above 6 millimeters, for sure there will be increased ICP. Between 5 and 6, there is still a gray zone. Okay, and this is a review by Chiara Robba, and well, they found a very good are under the curve for the detection of increased ICP by using the ONSD. The only thing is that sometimes in literature reported cutoffs may differ. Okay, and here I would like to show you some videos, homemade videos of how we perform transcranial Doppler. So here it is. I will speak over the video because I was speaking in Italian at the moment. So here I will show the sphenoid wing, the contralateral bone. Okay, that in the middle is the brainstem. Okay, it's pulsating. Now I tilted the probe superiorly, the third ventricle, the thalami. Now I go back to the mesencephalic plane and we see the vessels. So this is the MCA, the contralateral MCA, the two ACAs, and those are the PCAs that surround the brainstem, okay? At this point, we correct the angle, and we see the components of that was a patient with subarachnoid hemorrhage. So we are looking for vasospasms. We try to insulate the vessel in many points, okay? We record the vessel and the blood pressure, the mean arterial blood pressure. This is installation of the ACA. We correct the angle. We see that the ACA has got a flow going away from the probe. I hope you enjoyed the presentation. And the last thing that I want to say is that we need to keep in mind that ultrasound techniques are not perfect. And so always to know the limits of our techniques. Okay, thank you for the attention.
Morning to everybody. My name is Francesco Crabati, Professor of Anesthesiology at the University of Pisa and co-chair of the WinFocus World Congress 2024. It's really an honor to introduce the first scientific section of the day on ultrasound management of ventilation. Today, we have the chance to have with us 5 top publishers and worldwide recognized experts in the field. Let me introduce my colleagues. Sara Gomes from Universidade do Minho, Portugal, talking about assessment of the upper airways. Then Silvia Mongodi from University of Pavia, Italy, talking about titration of invasive mechanical ventilation by ultrasound. Then Maria Cammarota from Università Piemonte Orientale, Italy. His topic is non-invasive ventilation management by ultrasound. Cosmin Balan from Iliescu Emergency Cardiovascular Disease Institute, Bucharest, Romania. His topic is winning from mechanical ventilation, including non-invasive mechanical ventilation. And Peter Tuijman from University of Amsterdam, the Netherlands. He is an expert on respiratory muscle ultrasound in the ICU. At the end, don't miss the opportunity to join us, all the speakers, for a Q&A and live debates. You have the opportunity to submit questions during all the presentations and at the end of the session. So, dear colleagues, the floor is yours.
Good morning, everyone. My name is Sara Gomes. I came from Portugal. And first of all, I would like to thank for the invitation to participate in WinFocus 2024. So my presentation will be about assessment of the upper airway using ultrasound. I don't have any conflict of interest, but I am one of active member of these 3 communities of practice. So the purpose of my presentation today is to share with you what is the scientific knowledge related with the recent publications on the use of ultrasound in assessment of the airway, in the topics that you can see here on this content table. And at the end, I will also share with you some innovative applications that I'm willing to have in my daily practice. So let's begin with the prediction of difficult airway management. We know that we have many clinical predictors, but they are not reliable or consistent to use in our clinical practice. And in the last 10 to 15 years, many papers have been published and systematic reviews done related with the use of ultrasound parameters as predictors of a difficult laryngoscopy and difficult intubation. I will present you the most reliable and consistent ultrasound parameters that you can use on your daily practice. So those are the distance from the skin to hyoid bone, the distance from the skin to epiglottis, the distance from the skin to anterior commissure of vocal cords. And because the tongue is actually one of the first obstacles when you are doing a laryngoscopy, of course, the measurements of the tongue thickness, width and volume and cross-sectional area are also predictors of a difficult laryngoscopy. And all those parameters that I already mentioned have a direct correlation between their measurements and the grade of laryngoscopy. That means that the bigger the measurement of these parameters, the most difficult will be the laryngoscopy to perform. On the other way, there are parameters that are related with the distant iomental distance with a head in neutral extender, or even related with the ratio between iomental distance with neck extended and neutral that negatively correlates with the difficult laryngoscopy. That means that the smaller the dimension of this parameter, the most difficult will be the laryngoscopy to be done. So those are the parameters that you can use in your daily practice that are proved to be efficient as predictors of a difficult laryngoscopy. Nevertheless, we know that in nowadays, we're using more and more video laryngoscopes to approach our airway, especially if we have a patient with a predictable difficult airway management, because we know from the systematic reviews that the use of video laryngoscope will increase the success rate of the first attempt. So Miguel Vaquero published recently this paper where we identify 3 parameters that were actually predictors of a difficult video laryngoscopy when he used a McGrath video laryngoscope. And those are the distance from the skin to epiglottis, the distance from the skin to the deep point of the palatus, and also the surface, the tongue area, the sagittal tongue area with the patient awake. So those are the most important predictors that you should evaluate before you do an intubation using McGrath video laryngoscope. Nevertheless, there is some populations where we need to be aware of their differences, and especially when I talk about pregnant women, or when I talk about obese, or even in different contexts, such like emergency room or intensive care, where you don't have time to do a lot of measurements. So in this kind of patients, in this kind of context, which ultrasound measurement I should evaluate before I do an intubation. So, and we know that in this study that was published recently, they analyzed the anterior neck soft tissue thickness. I mean the distance from the skin to hyoid bone, skin to epiglottis, or skin to vocal cords, and they realized that these measures increases from the non-pregnant woman, which is group A1, to the pre-eclamptic patient, which is the group 3. So in this kind of patients, the measurement of the distance between skin to hyoid, skin to epiglottis, or skin to hyoid, or skin to vocal cords are reliable and consistent predictors to be used on these patients, and especially because they are actually very, very easy to perform. The same happens with obese patients, where you can see actually a direct correlation with the grade of laryngoscopy and also with difficulty in end mask ventilation. So what about emergency room? We don't have many time to do measurements before intubation in emergency room. But again, in this perspective and observational study, they conclude that the distance from skin to hyoid bone or skin to vocal cords are important predictors of difficult laryngoscopy that can be and should be evaluated before an intubation attempt with a sensibility and specificity of 70 and 85% respectively. So the other topic I would like to talk about is to guide and confirm tracheal intubation. We know there are many signs like the common tail sign, the double line sign, the change in esophageal morphology and shape when there is a esophageal intubation. We know that you can evaluate on a transverse view or a longitudinal cervical view. It is really easy to perform, and with high sensibility and high specificity even for pediatric patients. But we also know that when we have an esophageal intubation, the esophagus will really change its morphology. Here you see a normal esophagus. You can see perfectly well the posterior wall, and here you have an intubated esophagus with a double line sign with the posterior wall completely obliterated. But we also know that the dynamic approach to confirmed intubation is actually superior in terms of sensibility and specificity when compared with the static images. And you can see in this video from the Gottlieb study, you can see perfectly well that if you inflate the cuff with the saline, you can actually realize the positioning of the tube, you can see these double line images that represent the anterior wall of the tube. I would like to show you an esophageal intubation in a dynamic view. And again, you can actually realize that this dynamic image is actually superior to any static image. The only limitation about this approach is that you need two operators, one operator for the ultrasound and the other for the to perform the intubation. So another topic that I want to discuss is the importance of the ultrasound of the upper airway to guide the cricothyroidotomy. We know from the reports from the NAP4 there is a high failure rate of the emergent cricothyroidotomy. We don't know why, because they are difficult in identifying the CT membrane, or because there is a lack of training, because it is a rare event. Nevertheless, we know that ultrasound has superiority over the palpation method in identifying the CT membrane. And we know that if we combine the two approaches, the longitudinal approach, which we call the string of pearls, with a transverse approach that we call TACA, we can actually increase the rate of success to identify the cricothyroid membrane. And again, in this published clinical case, where you can see that actually in black, you have the palpation method identifying the CT membrane, and on red, you have actually the identification using ultrasound. And of course, the ultrasound is superior. There is no way to use not to use the ultrasound. So we can also mark the CT membrane. You can mark the CT membrane, but ultrasound allow us to get more information about the depth of the trachea at the level of the CT membrane. We can also find which is the length of the CT membrane. We can also identify many vessels that are in the middle line, that are lateral, and that can compromise the performance of the crico, or even that can be associated with a high risk of hemorrhage from the procedure. So, but the question is, should I mark all my patients? Should I mark the CT membrane in all my patients? Of course not. But in every patient that has a difficult airway management, that you predict that it will be difficult to intubate, or a patient where you are going to do fibrotic awake intubation, of course you need to mark your CT, the patient CT membrane. Nevertheless, be careful to double check your CT mark before doing the crico, because sometimes there is a change in the patient positioning, there is a change in the head position, and so it is very, very important if you can again double check the mark that you have previously done. So another use for our clinical practice of the ultrasound is actually to guide the percutaneous tracheostomy. Percutaneous tracheostomy is actually a very frequent procedure in the intensive care units, but is actually one of the risky procedures that we actually do in intensive care. The use of ultrasound increases the success rate, decreases the time for the procedure, decreases the number of punctions, and of course decrease the rate of complications. Is something that it was published in this and publishes in this study as actually results. And because I think that image is much better than any word, I would like to invite you to see this video. This is an approach for a tracheostomy. Before a tracheostomy, you can see the patient is intubated, and when you will look for the tracheal rings, we can see that there is the innominate artery makes a really arch in front of the trachea. And if you don't have any ultrasound scanning before the procedure, maybe this patient would not be alive to tell the story. So please use your ultrasound before even you think about doing a tracheostomy. So there are a lot of innovations related with these high-risk procedures, just like a percutaneous tracheostomy. And this is a new technique using a microendoscopic ultrasound-guided percutaneous tracheostomy. So there is a microendoscopic probe inside the needle that allows you to have in the same screen the visualization from the bronchoscope, from the endoscope, and the visualization of the ultrasound, so you can increase the safety of your movements and at least increase the safety of the procedure. There is another clinical use of the ultrasound when we want to predict the post-extubation stridor in our patients. So there is not a problem inside the operating room or the emergency room, but there is actually a problem, the stridor that appears after extubation in the intensive care units, and the incidence is quite variable depending on the units. But if there is stridor, there is actually the risk of reintubation and to increase the length of the stay of the patient, morbidity and mortality. So if you can prevent a post-extubation stridor, is something that it will have a positive impact on the patient outcome. So you can evaluate the length of the column of air if you deflate the cuff of the tracheal cuff of your patient. So if you see a column of air like this, there is no leak between the tube and the vocal cords. If you have wide column of air like this, this means that there is actually a leak between the tube and the vocal cords or the airway structures. So our take-home message is, this is really simple to do. This is really fast to do. You just need to use a linear probe and actually evaluate the length of this hair column. And this procedure has also huge big sensibility and specificity for this procedure. You can also evaluate vocal cord movement, mobility, morphology, and we can also study the velocity of displacement of the vocal cords. So I would like to share with you a video of one of my patients. The patient has an anaphylactic shock due to rocuronium in the 24 hours after extubation. You can see there is a leak there using the video laryngoscope, and if you can see also there is a leak when you deflate the cuff here inside the vocal cords. There is really a large column of air that represents there is no edema that compromise the ventilation. So the patient was extubated without any stridor and without the need of reintubation. When we talk about, now we will talk about the last topic, which is innovative applications. Of course, ultrasound are very important for to identify sonoanatomy, but also some injuries on airway cartilage, hematomas, fractures. We can also, ultrasound has actually a role in identifying necrosis of trachea in a patient that had really extended intubation time. As you can see, the images really correlates quite well between the ultrasound and the bronchoscope. And there is also another innovative application where you can use your ultrasound to guide your bronchoscope for a perfect intubation. So there is a metal magnetized on the bronchoscope, and the transducer can identify the orientation of your bronchoscope, so you can intubate the patient with a bronchoscope guided by your ultrasound. Just another clinical case to let you know that sometimes these simple clinical cases are really important for our awareness of what we can use. So this was an obese patient. The airway was very difficult to manage. Our colleagues used a laryngeal mask, and through the laryngeal mask, they introduced a bougie. So using a dynamic approach of the ultrasound, they were able to identify the bougie and identify actually the intubation and the proper positioning of the tube. And my last slide goes to the use of 3D airway ultrasound, that I think that will be an important educational tool for the future, and also will be really, really important for clinicians to plan the approach of a difficult airway when we can anticipate a difficult airway management. So this is the summary of the presentation. So we can use it to predict difficult airway management. Don't forget just to measure distance to skin to epiglottis, skin to eyelid bone, vocal cords. Some of the dimensions of the tongue are really predictive of a difficult laryngoscopy and difficult video laryngoscopy. Use your dynamic approach to guide the intubation and confirm tracheal intubation. Use the ultrasound to guide crical and tracheostomy, and scan your intubated patient before you extubate, so you can have a qualitative and quantitative view of the column of air with the deflated cuff. And of course, we are willing to see these innovative applications so we can go forward and increase patient safety. So thank you so much for your attention. I'm willing for your questions. Thank you.
We will see in the next minutes how we can use lung ultrasound to titrate and monitor invasive mechanical ventilation. These are my disclosure statements. We can use in ARDS patients lung ultrasound with many purposes, from diagnosis to phenotyping, monitor and titrate the ventilatory strategy, and detect complications. For most of these applications, we will need advanced lung ultrasound, which mainly consists in quantitative lung ultrasound. So we go beyond semiotic, which is useful for diagnosis, and we aim to quantify lung loss of aeration. You will find in literature multiple different quantification approaches that fit in different clinical settings. In intensive care unit, you have to use the lung ultrasound aeration score, which is also the only one that takes into account the presence of consolidations. This approach relies on the identification of 4 progressive steps of loss of aeration, going from 0 points when the aeration is normal, and you only see A lines or a maximum of 2 B lines. 1 point when artifacts as B lines or subpleural consolidation occupy less than 50% of the visualized pleura. 2 points when artifacts occupy clearly more than 50% of the pleura. And 3 points when we visualize a consolidation, so a tissue-like pattern. This score is applied as computed in each of the 6 regions per hemithorax, 2 anterior, 2 lateral, and 2 posteriors, giving a global lung ultrasound score that is the sum of the regional scores, and ranges therefore from 0 when all the regions are normal to 36 when all the regions are completely consolidated. When we compute the lung ultrasound aeration score, we know that we are reliably assessing lung tissue density as measured by the gold standard in this field, which is a quantitative CT scan. And there is a substantial agreement between the lung ultrasound and the quantitative CT classification, with a slight tendency of lung ultrasound in being somehow pessimistic. So if you are in doubt, just use the lower score you are thinking about in one region. This correlation between ultrasound and CT classification is tighter if you use the described approach based on the percentage of occupied pleura. In the first papers on the lung ultrasound aeration score, you will find coalescence defining the switch from score 1 and score 2. However, the approach based on the percentage of occupied pleura, as you can see, gives a much better correspondence with the CT classification. First application, we can phenotype ARDS. We know from CT studies that we can have a focal and a non-focal pattern in ARDS patients. The focal pattern present mainly not affected anterior fields, and these patients tend to hyperinflate more than recruit if recruited maneuvers and higher PEEP titration are applied. So we want to candidate focal patterns to prone positioning. In diffuse or non-focal patterns, on the contrary, we can see that anterior fields are also affected. These patients tend to positively respond to higher PEEP titrations, so we will candidate those patients to decremental PEEP trial. Constantin tried to demonstrate that this personalized approach based on the ARDS phenotype provided benefits in terms of survival when compared to a strategy based on a PEEP FiO2 table. However, if we have a look to the overall population, we can see that the personalized group did not actually offer any benefit in terms of survival. However, we have to consider that up to 20% of those patients were misclassified. So they were treated as a diffuse pattern while they were focal or vice versa. And this is mainly due probably to the fact that the most frequently used imaging tool in this population was the chest X-ray. So if we just consider those patients that were correctly classified, we do actually see a benefit in the personalized strategy. But we also realize that we need a reliable tool for this classification because misclassified patients actually show a severely impaired survival rate. The first data on the potential use of ultrasound for this purpose now date back more than 10 years, and the focus is on the aeration of anterior fields. Many different approaches based on the aeration of anterior fields have been tested compared to quantitative CT scan. As you can see, they all present extremely good accuracy in terms of area under the curve. I think the easiest is probably the best to be applied in clinical practice. So if you just compute the score in the 4 anterior fields, and this score is above 2, then this identifies non-focal patterns. So if anterior lung ultrasound score is above 2, then the patient is a diffuse phenotype, and you recommend a PEEP trial for this patient. If the anterior lung ultrasound score is below or equal to 2, then this patient is a focal phenotype, and you would recommend prone positioning. You have, however, to keep in mind that lung ultrasound will not tell you which is the adequate level of PEEP you have to set. So you normally need to integrate lung ultrasound in a multimodal lung monitoring. For example, we now use a method based on decremental PEEP trial and analysis of a pressure modeling curve from PEEP to plateau in order to set the lowest PEEP level, allowing to avoid intratidal recruitment and therefore lung hysteresis below 100 ml. Once you have decided to candidate your patient to PEEP titration and you have set the adequate level of PEEP, then you can use lung ultrasound to monitor recruitment. The first data on the potential real-time visualization of recruitment come from the operating room setting. Many studies, in fact, demonstrated that an ultrasound-guided recruitment during surgery improved lung aeration and reduced atelectasis at the end of the intervention. However, we are here speaking about healthy lungs of people under general anesthesia undergoing surgery, so a completely different context. When we tried to compare the variation of lung ultrasound scores to recruitment as measured by quantitative CT scan, we disappointingly found no correlation. However, we have to keep in mind that what CT scan considered recruitment is tissue recruitment, so gaining inflation of previously not aerated tissue. So, for example, if we switch, as in this case, from a score 2 to a score of 0, the lung ultrasound score variation is 2, but the CT recruitment will be 0% because there is no not aerated tissue at the beginning of recruitment. And on the contrary, if we observe a reduction in the dimension of the tissue-like pattern, lung ultrasound score will not detect it, but CT recruitment will detect an improvement in aeration. So the variation of lung ultrasound scores and the tissue recruitment measured by quantitative CT scan really look at different things. So they cannot be compared. We also have to say that quantitative CT scan is not the only method to measure lung recruitment, and it's surely not the most frequently used in clinical practice. And actually, when compared to other methods, a strong correlation could be found with recruitment measured by pressure volume curve in a decremental tip trial, which is air recruitment, not tissue recruitment, with recruitment to inflation ratio, and to improvement in gas exchanges. So we can use the variation of lung ultrasound score to detect recruitment. And we can also extend our ultrasound examination to monitor the drawbacks of higher peak titration and recruitment maneuvers. We normally applied it after each recruitment maneuver or in case of acute deterioration. We can in fact detect overinflation, although not formally proven, which normally corresponds to a reduced lung sliding. Pneumothorax can easily be ruled in or out with the analysis of pleural movement, but we can also observe the negative side effects of increased intrathoracic pressure on the right side of the heart. And maybe we can observe an intracardiac right to left shunt if we opened up a previously closed patent foramen ovale, or an acute pulmonary, or maybe even better, an acute RV injury. A particular population that has to be taken into account is the PIP setting in brain-injured patients. In those patients, we observe that most of the loss of aeration is in posterior fields, and those fields are also the most informative to predict the impact of an increased PIP on intracranial pressure. And what was observed is that the higher the lung ultrasound score in the posterior fields, and the smaller was the change in intracranial pressure. And in this study, there was also an initial observation on the potential interest of dynamic pintiform air pomphogram to distinguish the recruitable patient and the not recruitable ones. Similarly to what performed for the monitoring of PIP titration, we can also monitor the effectiveness of prone positioning. As expected in these patients, the main improvement is observed in focal ARDS, which are in green in this figure, and in posterior fields, both in COVID and non-COVID patients. Again, the main improvements are displayed in posterior fields. Sometimes longer time is required. Here we have the comparison between early, after 1 hour, and late, after 16 hours of prone positioning. And the re-aeration measured by lung ultrasound score variation correlated with the end expiratory lung volume increased as measured by automated nitrogen washout washing technique. So another measurement of recruitment, and this correlation was tighter in the late prone positioning, and it showed also correlation with improved gas exchanges. Similar finding in the interest of monitoring posterior fields in prone positioning has been shown in awake prone positioning associated to iflorescent cannula, which was a treatment frequently applied in COVID-19. Finally, we can use the daily lung ultrasound score to monitor the overall lung recovery. In this preliminary ARDS population on veno-venous ECMO, we observed that each patient with its own pace show a progressive reduction of the lung ultrasound score, which corresponding to a progressive improvement of lung aeration. So it corresponded to lung recovery. On the contrary, this last patient, who never showed significant reduction in lung ultrasound score, clinically never show any improvement, and we were never able to win in ECMO. In this particular population, the possibility to monitor at the bedside in a reliable way the lung aeration is even more important, because chest X-ray is extremely poorly informative, and transportation to radiology department may be quite complicated. Similar findings were observed again in ARDS on veno-venous ECMO. This population is distinguished in survivor, win from ECMO but not survivor, and never win from ECMO. As we can see, they start from similar lung ultrasound scores, but they have a very different trend. After 1 week, the survivor improved. The win from ECMO but not survivor improved, but not as much as the previous population. And we cannot see any significant improvement in the lung aeration of patients who could never be weaned from ECMO. Finally, sometimes in the monitoring of our patient, we can observe an unexpected increase of the lung ultrasound score, so an unexpected worsening of the lung aeration. And in this first case series of COVID-19 patients, this frequently corresponded to overinfection, so ventilator-associated pneumonia. We applied this same concept to our COVID-19 population, and we observed that the higher the worsening, so the higher the variation of the lung ultrasound score, and the higher was the specificity for ventilator-associated pneumonia. However, we have to keep in mind that lung ultrasound score is very unspecific. It just tells you that the aeration is worsening. You then have to understand why, and if you suspect an overinfection, so a ventilator-associated pneumonia, then you have to look for specific signs, as you can see in the right bottom corner, which is a dynamic linear arborescent bronchogram. So overall, you can use lung ultrasound as a very functional imaging in your ARDS or in general intubated patients to phenotype the acute respiratory failure you are facing, and to decide and monitor the ventilatory strategy, and also to rule out easily the complications of your strategy. Thank you.
Good morning to everyone. I'm Gianmaria Camarota from Alessandria, Italy, and today I will speak about ultrasound-guided non-invasive ventilation management. Here is my disclosure statement. So, non-invasive respiratory support is a conventional and well-established practice to face off acute respiratory failure, both inside intensive care unit and outside ICU. Also, inpatient serving do not intubate or there's limitation. During non-invasive respiratory support, several monitoring strategies have been proposed encompassing clinical, physiological, ventilatory, and cardiac parameters monitoring, along with imaging evaluations. Why? Because during non-invasive respiratory support, patients may experience injury on the lung due to patient's self-inflicted lung injury or respiratory muscle for improper regulation of non-invasive respiratory support settings such as under assistance, over assistance, and asynchrony events occurrence. Also, we have to consider the key role played by comfort, that is a well-known factor for non-invasive and non-invasive respiratory support failure. So let's talk imaging evaluation with particular regard to ultrasonography. In speaking about ultrasound, we refer to echocardiography and ultrasonography for lung and diaphragm. Let's provide more insight about echocardiography. Echocardiography is a useful tool employed since the beginning of respiratory assistance to identify known or suspected air disease, but also to follow up air condition during treatment. We know well that non-invasive respiratory support is a well-established therapy employed to face off acute respiratory failure due to acute air failure. Echocardiography is a well-recognized tool to assess left-sided chamber dimension and function in terms of systolic and diastolic function, as well as right-sided chambers in terms of dimension, kinesis, Doppler evaluation, inferior vena cava assessment, and venous extended ultrasound. In the same consensus, the role of lung ultrasonography has been well described. Let's move to ultrasonography for lung and diaphragm. Lung and diaphragm ultrasonography is a well-established tool to assess basic and advanced monitoring of patients admitted with acute respiratory failure. Why? Because lung ultrasound has been clearly demonstrated to be a useful tool to avoid patient transport outside ICU or ward, to reduce radiation exposure, to allow cost saving, and is characterized by good diagnostic accuracy and is useful to predict clinical outcome. In speaking about lung ultrasound, we know well that two main approaches are described in terms of lung ultrasonography assessment. A qualitative approach that is useful to rule out the condition underlying the acute respiratory failure, and a quantitative approach that is useful to quantify the lung loss of aeration. In regard to lung ultrasound quantitative approach, Chiumello and co-workers described the association between regional lung ultrasound score and lung tissue density as assessed through Hounsfield unit. The author stressed several limitations in doing this, with particular regard to not aerated and poorly aerated lung tissue and higher regional lung ultrasound score. To overcome this limitation, the author suggests to attribute regional lung ultrasound score on the basis of lung aeration predominant pattern and pleural involvement below or beyond 50%. So, during non-invasive ventilation, lung ultrasound is useful to identify the cause underlying acute respiratory failure, assess lung aeration, quantify lung aeration, and monitoring lung recruitment. In this setting, by Licher and co-workers, lung ultrasound has demonstrated to be useful to identify patients at risk of poor outcome. In fact, patients with a lung ultrasound score higher of 18 experience higher mortality and higher initiation of invasive mechanical ventilation compared to patients with the lung ultrasound lower or equal to 18. And always in the same setting, lung ultrasound score per point was demonstrated to be an independent risk factor for mortality, for need of mechanical ventilation, and for a composite clinical outcome encompassing both mortality and invasive mechanical ventilation. So let's move to ultrasound for diaphragm respiratory muscle. In particular regard, the diaphragm ultrasound has been described to assess diaphragmatic thickening and diaphragmatic excursion. Diaphragmatic thickening fraction is a surrogate of diaphragmatic effort. In this setting by Vivier, it was well demonstrated that at increasing diaphragmatic pressure time product did correspond an increasing in diaphragmatic thickening fraction. In this other setting by Mercurio and co-workers, addressing the diaphragmatic function in patients admitted for de novo ARF and undergoing non-invasive ventilatory support, patients who experience NAV failure were characterized by a lower diaphragmatic thickening fraction compared to NAV success. In this other setting by our team, enrolling patient undergoing non-invasive respiratory support due for acute respiratory failure secondary to COVID-19 disease. Diaphragm and lung ultrasound were performed in awake patient undergoing NIV in supine and prone position. We found an increasing in diaphragmatic thickening fraction, switching from supine to prone position. In addition, we found a relationship between comfort score and thickening fraction. In fact, at rising of comfort score, there was a reduction in thickening fraction. Lastly, we found that the patients who experienced knee failure were characterized by higher diaphragmatic thickening fraction compared to NAV success within the 30 hours following study. Let's move to diaphragmatic excursion, and in this setting, addressing patients undergoing NAV for acute respiratory failure, we found that patients not responding to NIV were characterized by a lower diaphragmatic excursion compared to NIV responders. In this other setting of Always from my team, we assessed patient we admitted to emergency department for acute hypercapnic respiratory failure, and we found that patient who responded to NIV at 2 hours from the beginning of respiratory assistance were characterized by higher diaphragmatic excursion compared to NIV failure as defined by EMOGAS analytic criteria. So, in patient undergoing non-invasive respiratory support, ultrasound is a useful and repeatable tool to screen patients with more lung involvement and more severe condition at the beginning of our treatment, and is also useful to follow clinical evolution during treatment. So let me the chance to introduce Meet Venus study, that is a worldwide multi-center study focused on respiratory complication after surgery. I asked to join us to contribute to Meet Venus study. Thank you very much for your attention and enjoy WinFocus World Congress 2024.
Hi, hello everyone. My name is Cosmin Balan. I'm a consultant intensivist currently working in Bucharest, Romania. I'm going to present for you for the next 15 minutes weaning from mechanical ventilation using ultrasound. I have no conflict of interest related to this presentation. The synopsis of my presentation includes answering two very related questions. How can ultrasound predict weaning success and help avoid weaning failure? And second, how can ultrasound diagnose the underlying causes of weaning failure? So let us consider the mechanisms leading to weaning failure, each with its own specific time domain. The neurological factors, including impaired central drive, impaired airway control, oversedation, anxiety, glottic edema, secretions, obstructions for airway factors. For lung factors, we have derecruitment, pulmonary edema, atelectasis, unsolved lung disease. For respiratory muscle factors, ventilator-induced diaphragmatic dysfunction. The cardiocirculatory factors include increased LV afterload, increased venous return, radiant ischemia, unmasked diastolic dysfunction. Then we have metabolic factors including acid-base abnormalities, hypophosphatemia, cortisol insufficiency, and lastly, the overweight, malnutrition, and critically illness, myopathy or neuropathy. So how can I use ultrasound? In an ABCDE approach, I will use ultrasound to look and assess the aeration score. Look below the diaphragm, look at cardiac factors, assess the diaphragm, and maybe access extra diaphragmatic muscles. Of all these factors, these three, the below diaphragm factors, the diaphragm, and the extra diaphragmatic factors, they are static, meaning that by themselves, they are not self-sufficient to cause weaning failure. And secondly, they are static because the pre-spontaneous breathing trial status will be very similar very often to the post-spontaneous breathing trial status. Let's delve a little bit into detail and look at diaphragm ultrasound. This study is from 2019 and provocatively showed that there was no difference between patients who succeeded and patients who failed in terms of diaphragm excursion, neither right nor left. Patients were similar in terms of right thickening fraction, right and left. So this study shows that diaphragm dysfunction may be actually a bystander in weaning failure, weaning success. It's another study more recent, aligns well with the previous one, showing that diaphragm dysfunction is a common occurrence in weaning patients, in patients who succeeded in weaning. 41% of patients who had success had a less than 30% thickening fraction, meaning that you can do well even if you have diaphragm dysfunction. So is it that diaphragm dysfunction is a mere bystander and nothing more? This is a study from a different population, but it's quite interesting because it shows that at least in patients with acute hypercapnic respiratory failure getting non-invasive ventilation, diaphragm dysfunction, diaphragm excursion specifically, is predictive for non-invasive failure. So might that be that diaphragm dysfunction is a culprit, at least in this patient population? Well, it's not. It's a mere marker of airway air trapping for patients with acute hypercapnic respiratory failure and nothing more. So it can actually be that diaphragm dysfunction in the general population of the hard-to-wean patients might be nothing more but a marker of the severity of the underlying disease. However, a permissive role on weaning outcomes for diaphragm dysfunction cannot be discarded, at least based on this very recent study from Golliger and collaborators. This study showed that both disuse atrophy and hypertrophy produced by load injury are associated with a reduced likelihood of liberation from mechanical ventilation. And just to highlight the permissive role of the diaphragm dysfunction, let's look at this case, 45 male, post-operatively, 48 hours after cardiac surgery with sternotomy. The patient was about to get extubated when we captured these views. The lung ultrasound was perfectly fine. The cardiac ultrasound was unnoticeable, but the diaphragm ultrasound clearly shows right-sided diaphragmatic dysfunction with an excursion of 0.8 centimeter compared to 3.2 centimeter. This patient got extubated safely, never got intubated again, showing that diaphragm dysfunction is nothing more but an aggravating factor. It's not self-sufficient by itself to cause weaning failure, and other factors must be present for weaning failure to happen. The future looks promising for diaphragm monitoring. This study was published recently, and it shows that nowadays we can monitor the diaphragm continuously, and one can envisage even new metrics to assess diaphragm function, like the first derivatives of diaphragm velocity. We can now look at extra diaphragmatic muscles. We can look at intercostal muscles and abdominal muscles, and this is a new promise on the horizon. And extra diaphragm assessment could be really helpful to track changes over time in respiratory muscle structure, assess activation of these muscles during key events like spontaneous breathing trial, monitor the development of respiratory muscle weakness, and identify potential new complications in weaning from mechanical ventilation. Let's look at this dynamic duo, the heart and lung factors. First, this is a dynamic pair because lung factors can influence cardiac factors, much like cardiac factors can influence lung factors. Second, the pre-spontaneous breathing trial often is very, very, very different from the post-spontaneous breathing trial status. And ultimately, these factors by themselves are self-sufficient to cause weaning failure. Weaning is nothing more but a dynamic cardiocirculatory stress test, a stress test that challenges the cardiocirculatory system and ultimately elicits an increase in LV afterload, LV preload, and a decrease in LV compliance, the extent of which will ultimately define how much of an increase we're going to see in the LV and diastolic pressure. Now, because the winning trial is nothing but a stress test that challenges the biventricular functional reserve, it follows that preload independence is nothing but a harbinger of winning failure. And this was actually proven by Dress and collaborators back in 2015. But what it's more interesting to observe is that fluid intolerance and hence winning-induced pulmonary edema doesn't start the moment that fluid unresponsiveness starts, but it can start much earlier, depending on several aggravating factors, amongst which probably the most important are increased capillary permeability and low oncotics. Another concept worth considering when dealing with cardiocirculatory factors and winning-induced pulmonary edema is that systems, cardiocirculatory systems that are prone to develop winning-induced pulmonary edema have short time constants. The clinical message is that patients can get really well or really bad in a matter of minutes. So whenever we are dealing with a potential winning-induced pulmonary edema, one should have to perform echo very close enough to winning to the event. If we would like to predict what's going to happen during the winning process, one should have to use diastolic stress tests such as the passive leg raising test. So why does the pulmonary venous pressure rise in winning-induced pulmonary edema, and what would be my key ultrasound targets? Ranking them from low to the highest in importance, I would have to start with the LV systolic function, followed by stress volume increase by mean systemic filling pressure, and ultimately ending with the diastolic LV factors. So integrating these concepts, cardiac ultrasound can be used throughout the entire spontaneous breathing trial, before, during, and at the end. I could use ultrasound way before the spontaneous breathing trial to aid in risk stratification, to choose the right candidates, to not choose those with grade 2-3 diastolic dysfunction, LVF less than 40%, relevant valvulopathy, PLR negative, VEXAS positive grade 2-3 patients. These patients are in need of further optimization. But if I start the spontaneous breathing trial, during the spontaneous breathing trial, I can use ultrasound to optimize real-time the therapy, reassess wall motion abnormalities, reassess filling pressures, look for functional MRs, reassess RV-LV interaction, and reassess the preload dependence. And if failure happens, then I am bound to confirm the winning-induced pulmonary edema, meaning that I have to measure the E prime ratio, confirm WIPO by an E prime ratio higher than 12. Therapy-wise, there is a common denominator for all phases. I must adjust the fluid balance, and I must ultimately improve RV-VA coupling and LV-VA coupling. This one study is very recent, 2024, just got published, and shows that cardiac ultrasound is not able by itself to predict winning failure. How that goes? And it's about cardiac ultrasound and measuring E prime ratios. In contrast, the lung ultrasound score was able to predict winning failure with an area under the curve of close to 0.7 compared to 0.5 for E prime ratios. So the answer to this is quite simple. Cardiac ultrasound is not bad, but it's actually capable of just predicting winning-induced pulmonary edema. And winning-induced pulmonary edema is nothing but one of the many causes that will increase the lung ultrasound score, which ultimately is nothing but one of the many causes that can explain winning failure. So if we put it all together, here is a comprehensive ultrasound approach to winning a patient from mechanical ventilation. Whenever I'm considering a patient ready for a spontaneous breathing trial, I must first assess the clinical parameters. If these are fine, then I have to stratify patients according to the lung ultrasound score. Use a global or an anterolateral one, whichever. If this is okay, patients can be extubated safely. If the lung ultrasound score is increased, I must look for the underlying problem. And that can be winning-induced pulmonary edema, atelectasis, derecruitment, unsolved lung disease, or even diaphragm dysfunction. And one has to treat them separately and objectively based on diaphragm ultrasound and cardiac echography. My take-home messages are the following. Ultrasound can be used to ensure a comprehensive assessment to prepare the patient before weaning from mechanical ventilation. Ultrasound ensures risk stratification before the weaning starts. Ultrasound may help optimize the patient in real time. No single ultrasound examination can predict weaning outcomes, hence we must use a combination of examinations. And very important, WIPO patients are marked by short time constant behavior. Hence, baseline echo values alone cannot reliably predict the weaning outcome. Hence, the need for challenge tests such as the passive leg raising test. Thank you so much for your attention.
Hello, my name is Pieter Tuijman. I'm a professor of intensive care medicine in Amsterdam, and it's my pleasure to talk with you about respiratory muscle ultrasound in the intensive care unit. I have no conflict of interest related to this talk. The respiratory muscle ultrasound can be used to evaluate the anatomy and function of the respiratory muscle pump. As for all forms of ultrasound, it's a safe, repeatable, accurate, and non-invasive bedside technique that can be successfully applied in the ICU. Mastery of this technique allows the healthcare provider to rapidly diagnose and assess the respiratory muscle dysfunction in ICU patients and in patients with unexplained dyspnea. In my talk, I will briefly discuss the following topics. First, I will discuss how it's done. Then I will discuss why and when to do it. And lastly, I will give some insights into the future of respiratory muscle ultrasound. Let's start with how it's done. There are three parts of the respiratory muscle pump that can be easily assessed by ultrasound. First, there's the diaphragm, the main respiratory muscle. And second, ultrasound assessment of the accessory inspiratory muscles could add extra information regarding patients' inspiratory effort. Especially parasternal intercostal muscle ultrasound may be a useful tool to evaluate the capacity load balance of the respiratory muscle pump in ventilated patients. And also the ultrasound of the expiratory muscles, the rectus abdominis, external oblique, internal oblique, and transverse abdominal muscle can give information on function and strength of these muscles. Let's start with excursion. The ideal range of the probe is between 2 and 5 megahertz, so cardiac or abdominal transducer. Transducers should be aimed at the dome of the diaphragm, so through the liver at the dome of the diaphragm. And there's no consensus on transducer placement on the abdomen, but mostly it's in the mid-clavicular line. Gain should be adjusted to create ideal contrast with surrounding structures, and measurements are best performed in the M mode and during quiet breathing. You can see here the excursion, and you measure the distance, and it's a very nice distance of 4 centimeters. If you experience difficulties visualizing the diaphragm from the subcostal window, movement of the liver or spleen during tidal respiration can be used as an alternative. To this end, an intercostal window at the zone of apposition in B or M mode is advised using a low-frequency probe. In my opinion, the so-called PLEPS point from the Blue Protocol of Liechtenstein can be used and is almost 100% successful. So you see here the image on the left side, you see the spleen, the kidney, and the diaphragm. And here in this clip, you can see that you can assess function of the diaphragm, but you cannot quantify it because the lung is sliding into your image. But you have a qualitative assessment if the diaphragm is functioning. And this is especially important on the left side because the spleen has a less good acoustic window. When we look at thickening and thickening fraction, the ideal range of the probe is between at least a high frequency probe, so a linear transducer, and no consensus is achieved for preferring the B or the M mode. Transducer should be placed on the mid-axillary line between the 8th and the 11th rib, with the lung slightly or just moving into your image. The transducer should be placed perpendicular to the chest wall so that you can see all the three layers, the pleura, the peritoneum, and the fibrous layer in the middle, and depth should be adjusted just below the diaphragm, so 1 or 2 centimeters below the diaphragm, and gain should be adjusted to create an ideal image. And then you measure, you put your calipers just in between the pleural line and the peritoneum, and you measure thickness. And what you can do is measure it at end expiration and inspiration. You can calculate thickening fraction. So end inspiration minus end expiration divided by expiration. And in this clip, you can start it. You can see how it looked like in practice. So you see here the clear the lines and thickening of the diaphragm. For parasternal intercostal muscle ultrasound, it's best to perform it with a high-frequency linear probe positioned in the craniocaudal direction at the second intercostal space. Thickness and also inspiratory thickening fraction can be assessed. In healthy subjects, there's only thickening of the parasternal intercostal muscles during maximal efforts, and in ICU patients, the existence of a dose-response relationship between the respiratory load and the parasternal intercostal muscle thickening fraction is suggested. So higher load means higher thickening. And this thickening is calculated as the peak inspiratory thickness minus end expiratory thickness divided by end expiratory thickness. And also the same probe can be used to assess the expiratory muscles. So you place the probe in a transverse orientation approximately 2 to 3 centimeters above the umbilicus and 2 to 3 centimeters lateral from the midline. Maximum muscle thickness is obtained by sliding the probe in a craniocaudal direction while keeping the probe perpendicular to the skin. Next, the probe is moved laterally, and the semilunar line is first identified as thick echogenic fascia that blends lateral to the rectus abdominis muscle and medial to the oblique muscles. And then you can assess the external oblique, the internal oblique, and transverse abdominis muscle identified as 3 parallel layers. So if we summarize how to do it, it's important to think about patient position. For diaphragm, it's okay if the bed is elevated a bit. For expiratory muscles, it's better when the bed is completely flat. Think about the probe. So you need a high frequency probe for thickness and a low frequency probe for excursion. Mark the probe location if you want to assess thickness over time, because it's important. And thickness, there's variability for different parts of the diaphragm. And also, I haven't discussed before, but ventilator setting is important. So it's preferred to do the measurements without any support or PEEP of the ventilator, especially for excursion, because you can divide the excursion provided by the pressure support or by the patient. So preferably do it without support of the ventilator. If the patient is cooperative, ask for a maximal breath, so you can compare it between the tidal breath and the maximal breath to see if there's any reserve, and use the plethsporin as an escape. So why and when to do it? I will discuss some indications. I will discuss that combination of measurements is preferred, but also the timing of measurement is important. The main indications at this point, in my opinion, are in patients with dyspnea of unknown origin, excursion, and thickening friction of the diaphragm are highly sensitive and specific and come without any limitations. In difficult weaning, you can use different parameters. So look at excursion, look at diaphragm thickening friction. intercostal muscle thickening fraction, but also the ratio between those two. And the diagnostic performance of those measurements differs a bit, because in some patients diagnosed with diaphragm dysfunction, for example, they can be extubated successfully, and also some of these measurements need further validation. And I also think that when you want to have an idea of the respiratory load capacity balance, that a combination of thickening fraction of the intercostal muscles with the diaphragm thickening fraction is a very good measurement. However, its role in muscle protective ventilation is still unclear. So in patients with respiratory failure or weakness as the major cause, it's uncommon. But it should be considered if more common causes of respiratory failure have been excluded. The clinical presentation depends on the cause and also the severity and rate of progression. But what you have to do is to compare the excursion of the both sides, so the right side and the left side. And what you can see here, that we have on the right side a very good excursion. However, on the left side, there's almost no excursion. So there is weakness of the diaphragm on one side. And if you want to look for paralysis of the diaphragm, what you can do is also compare both sides. And as one of the sides of the diaphragm is paralyzed, the negative pressure which is transferred to the abdomen results in an inward movement of the abdominal wall. And the ultrasound measurement of this is a cranial excursion of the diaphragm during inspiration. So you see movement of the diaphragm away from the probe. And in addition, severe isolated diaphragm weakness results in an increased thickening fraction of the accessory respiratory muscles. In weaning failure, there are different measurements possible. And this is a meta-analysis quite recent with 19 studies, more than 1,000 patients. And they divided patients into groups based on the measurement, but also the timing of the measurement, so during pressure support or during a spontaneous breathing trial, but also with different cutoffs. And they also compared thickening fraction to diaphragm excursion and to the rapid shallow breathing index. And what we can learn from this table, it's a large table, I won't discuss it in detail, is that first, the importance of timing and ventilator setting. So your accuracy of the measurement is dependent on the setting, and it's better to do it during a spontaneous breathing trial. And there are different cutoffs affecting, of course, your outcome. And also excursion is less accurate than thickening friction. In my clinical practice, I always perform both, so that I see if they align and they add information, I think. So I would advise to do them both. If we think about disbalance of the capacity and load of the respiratory muscle pump, if there's a high respiratory load with low inspiratory muscle capacity, what we will have is that there will be recruitment of the accessory respiratory muscles. So this helps us to see if we have a thickening fraction or excursion of the diaphragm, we don't know if it's enough for the load placed on the diaphragm. But if there's recruitment of the accessory respiratory muscles, then maybe the load is too high. And therefore, people have studied extra diaphragmatic inspiratory muscle ultrasound. And what they found was here on the left, that the thickening fraction of the intercostal muscles will go up if pressure support goes down. And they also found that the intercostal thickening fraction was higher in patients with lower pressure, transdiaphragmatic pressure. So with weaker diaphragm, higher intercostal thickening fraction. And they also looked at which measurement had a good accuracy for detecting the risk of extubation failure. And what they found was that parasternal intercostal muscle thickening friction divided by diaphragm thickening friction was maybe the best measurement. So this load capacity balance is best assessed maybe by combining those measurements. Another study was done, published in Chest, and it has a bit of the same results, but now they looked at the expiratory muscles, and what they found was here's the thickening fraction during cough of the expiratory muscles. in patients who had a failed liberations, thickening fraction was much less than in patients who had succeeded or in healthy subjects, and also the probability of reintubation was higher in patients with a lower strength of the expiratory muscles assessed by ultrasound. Then, if you look at this thickening fraction of the intercostal muscle to diaphragm ratio, then in this study by De Moule and Dress from Paris, they found indeed that thickening friction of the intercostal muscles was higher in patients with extubation failure, and also thickening friction of the diaphragm was lower. And combining these two measurements, what they did here, the ratio, and they found that the ratio of thickening friction, so higher intercostal muscle thickening friction, lower diaphragm thickening friction, result in a higher ratio in patient extubation failure. It's also important to think of the timing of the measurement, because if you do it before an SBT, you can detect high-risk patients. If you do it during an SBT, you can predict maybe weaning success, and after a failed SBT, diagnose the cause of failure. And this is important because this study showed that in patients who succeeded their SBT, there was no difference in thickening fraction of the diaphragm between success and failure. So if these results indicate that you should not base your decision to extubate patient only on ultrasound measurements, and in these patients, for example, cuff strength was a better predictor of outcome. So combine the clinical picture with your ultrasound measurements. In summary, why and when to do it, use it for diagnosing dysfunction, combine different ultrasound parameters to guide weaning, and these parameters together give you a best assessment of the load capacity balance, and timing affects your outcome. Lastly, a short view into the future, and I will look at combination of different ultrasound parameters to guide weaning and automation of image acquisition. So, in short, if you combine measurements, it may be preferred to look at the lungs, the heart, and the diaphragm, because these measurements give extra information. And maybe even do it bigger. So look at aeration, look below the diaphragm, look at cardiac function, but also diaphragm and extradiaphragmatic respiratory muscles. And this is also a very nice look into the future. In this study by Alexander De Moule, they had a continuous measurement of diaphragm excursion for half an hour. And what they found that it has a very good agreement with measurements done by the doctor. So you have the excursion continuous measurement with the measurement by the doctor, and there was a very good agreement, and also it's correlated with weaning failure and success. So in summary, respiratory muscle ultrasound is quite an easy and accurate tool and non-invasive if you follow and master some basic principles. Use a standardized approach. You can use it to diagnose diaphragm dysfunction, diagnose the cause of weaning failure, and assess respiratory load capacity balance. Combine these parameters of diaphragm and intercostal ultrasound, and also combine it with measurements of other organs. And I think in the future we will have continuous measurements for a longer period, so we don't have the problem of the timing. And these continuous measurements give us a better overview of the function of the diaphragm. I thank you for your time, and this is the end of my talk. Thank you very much.
Okay. Good morning to everybody, and thank you to being here with me this morning.
So in the next minute for me will represent a great opportunity to be able to get in touch with you, all panelists and speakers. So if you agree, I would propose to follow the flow of the session, because we have a lot of questions arising from the floor. And be aware that during all the section, all the delegates will be able to submit questions in order to be answered real time by all the speakers. So I would start with Saba Gomez.
Hi, good morning, everyone.
Good morning, Saba. Good morning, Saba. Personally, I want to compliment for your very, very interesting speech. And one question is why to use ultrasound in the assessment of the upper airways? So any benefit over the clinical assessment alone?
Oh yes, I think we actually should include the airway assessment on the POCUS approach to all patients, especially the patients that you need to manage the upper airway, because we can predict difficult laryngoscopies and difficult intubation in some of patients that if we look for the clinical predictors, we were not allowed to identify those patients as a difficult airway. So I think we can, first of all, and actually answering some of the questions that our colleagues already mentioned, I think we should introduce ultrasound in our daily clinical practice. First of all, and I think this was a strategy that was actually that succeeded for me, is that if you can recognize your own sonoanatomy, so if you scan in your upper airway, you will identify all the structures, and it will be really easy to identify on a patient whenever you need. So my answer is, yeah, the ultrasound, even for the upper airway, is the future. And also, I think it is really important for not only for prediction, as I said in the presentation, but also as a way to increase the safety of your patient. When you know you have a patient with a really thickness anterior wall of the neck, you know that if you need a cryo, you will have a lot of difficulties even in the palpation method. So for me, just only to predict, but also to scan for the cricothyroid membrane is something that it is really useful, and actually also for the tracheostomy as a scanning, like you will identify some issues, or you will identify a lot of problems, and increase safety on patient management for sure.
So thanks a lot, and I would like to discuss someone from the panel is used to perform upper airways ultrasonography, and in which context. So, for example, I can share my experience, not expertise, but experience. For example, up to now, I'm used to assess ultrasonography in the upper airways before tracheostomy, but today we had the chance to know that upper airway assessment by ultrasound is much more than this. And what about you, colleagues? You are used to perform upper airways ultrasonography?
Yeah.
Thank you.
We normally do a systematic assessment
before a percutaneous tracheostomy to assess vessels, or also the site of puncture to better identify the correct annular space. This is what we normally do. And very rarely also to give it.
Okay, there is a lagging connection. Thank you. And you, Gian Maria?
Yeah, we usually in my center perform airway ultrasound to predict difficult intubation, for example, and so to switch for an awake intubation procedure, or as shared previous by Silvia, before to perform tracheostomy in ICU patients. So we add ultrasound to common scores and examination for awake intubation to decide if move towards awake intubation with fibroscope, for example, or proceed with conventional intubation with conventional laryngoscope or video laryngoscope assistance too.
Yes, thank you, because I think that concerning all the section, there are common pitch on where we are playing on, but many times depends on the setting, being very different from pre-hospital or ICU, for examples, or emergency ward. You, Cosmin?
Sorry. I didn't pick it up.
In cardiac surgery ICU, what is the role of upper airways ultrasonography in this specific field of application?
Yeah, we actually use it only to guide tracheostomies, mostly. I would say 90% of cases, this is how we use it. We rarely use it to predict stridor afterwards, but we've been using it for quite a while to guide tracheostomy and to avoid any vessel-related mishaps.
Okay, thank you very much. And for me, first, is really a chance to have the chance to meet with you today. And if I may, because you raised the stridor, I would ask a question concerning the vocal cord motility. I don't know the answer. I don't have the answer. But a very, very tricky issue is to depict a vocal cord palsy after a thyroidectomy. So any one of you colleagues have any experience concerning that point?
I have not experience in the clinical setting, but in School of Medicine setting, yes, because I usually apply ultrasound during anatomy course to show the patient the motility of several structures, but also the motility of vocal cord too. So in clinical setting, no, but in academic setting, yeah. Okay.
Yeah, I agree with Gian Maria. And also it's difficult to measure velocities of displacement, but it's really easy to find asymmetries on a retinoid's location. So if there is something that we can start to do, is just to look at of a retinoid's cartilage and find out if they are symmetric or asymmetric, which is actually really easy to see. And it's like, I think it's usable.
Sarah,
Thank you.
sorry. Any chance you can do such examination also when the patient is still intubated? So
Yes.
to decide whether to proceed to extubation.
Yeah, you can see asymmetries while the patient is intubated. You can see asymmetries on the arytenoids cartilage. But you cannot measure velocities of displacement. It's not easy to do that because of the shadow of the tube.
Okay, thank you. This is a very, very important question and answer because in our ICU, we performed nearly 1,000 steroidectomy for here, and many times before the operating rooms, patients already had a chordal palsy. So the issue is to move the tube or not, because the suspect of a bilateral palsy is high. I tried several times. I read a lot of manuscript, but so now your suggestion is, okay, it's tricky, but try to look to arytenoids much more than vocal cords, for sure, because to the shape of the tube, okay?
Yeah.
Thank you.
Yeah.
Thank you.
Thank you.
Can I ask Sarah a question? Sarah, I really liked your talk, and we only use it for percutaneous tracheotomy, but I'm inspired to do it more. But I had one question. If you want to look at the vocal cords, although there's a correlation, isn't it better just to do a visual inspection because you can see more and have a better idea of what's going on? Or do you think it's so good ultrasound that it can replace visual inspection?
The visual, I think the ultrasound will actually be more useful than the visual inspection because it's non-invasive and it's really easy to do compared with the fibroscopy just to do it. So I think we need to train our eyes also actually as like, a learning curve, but actually I think that's the point. That's the way to go.
And my question was, how did you implement it in your clinical practice? So how did you start teaching your colleagues?
Yes. Yeah, our protocol is every patient that has thyroidectomy we scan the vocal cords, we measure the velocities, we look for asymmetries, and then we look only for asymmetries when the patient is intubated before being extubated, because it's not comfortable for the patient having completely muscle strained. So when we revert the muscle relaxant, the patient is intubated. So it's not comfortable for the patient. So we just look for the symmetries. After the surgery, then we extubate the patient. And then we look again for asymmetries and for vocal cords velocities on the post-operative period, like in the recovery.
Thanks a lot, Sarah. A bit of a rest, but we will come back to you. I would like to have the chance to allow all the panelists and all the delegates be aware. We have Silvia Mongodi, and I had a lot of questions to be answered because she's a world-leading expert in the field. But only one from my side, and then for you, Silvia, very, very important, especially in the critical care setting on mechanically ventilated patients, lung ultrasounds. But the question is, there is a patient who for sure needs a lung ultrasound assessment compared to another, and all our efforts in order to promote lung ultrasonography in this kind of patients? What kind of benefits are expected?
Okay, so very wide question. Thank you, Francesco. We could talk about half an hour. I think that the main indication is whatever patient has a respiratory issue. It can be a postoperative patient with new hypoxemia or a patient admitted directly for acute respiratory failure. All those patients, I would recommend a lung ultrasound examination because it's quick, it's bedside, it's very accurate. So the question is, why not, actually? And in the management, in particularly of patients with acute respiratory failure, I think we don't have to necessarily think about ultrasound as an alternative to CT scan because they can be integrated in the management. CT scan is very accurate, I think essential for initial assessment, but it's not a monitoring tool. We cannot repeat it as much as we want. We cannot do it at the bedside when the patient deteriorates. So we really need to integrate these two tools. What I think is very not necessary now is chest X-ray because it's so much less accurate than lung ultrasound. And okay, it still sees some things that we cannot see with lung ultrasound. For example, where did my chest drainage ended? So this is something that we cannot exactly locate with lung ultrasound. So there are still some indications, but not so many. Of course, the problem is that not everybody feels comfortable with the lung ultrasound assessment. So we are moving to a daily assessment with lung ultrasound, but there are still some colleagues that prefer to see the chest X-ray because they are more used to it and they feel more comfortable to see it. But I think that we have already seen a significant reduction in CT scan and chest X-ray since we started using lung ultrasound systematically. And the benefits are in terms of the quickness of the exam. You do it at the bedside, you irradiate less the patient, of course, but you also provide a more adequate and more prompt treatment to a specific respiratory disease.
You are brave, you are outstanding, and a brave woman, and I love brave women. And I fully agree. But I would like to ask to all the delegates that are connected and all of you colleagues, panelists, the chest X-ray is widely used worldwide. So, what do you think? Do you agree with Silvia or not? Please, Peter.
I fully agree with Sylvia. I think only the plastic you can see on very well on a chest X-ray. Oh, sorry, on an ultrasound. You can see it better on a chest X-ray, but it's very hard because it's easier to push a button and ask for a chest X-ray than go to the bedside because it will cost you a couple of minutes to examine the patient. But I think it's very worthwhile because if you go to the bedside, you have an interaction with your patient. So you see not only your ultrasound, but also other things going on in your patient. And always when the chest X-ray comes back, it may be this or it can be that. I cannot exclude this. And then you still have to go to the bedside and do an ultrasound. So I think in the end, it's much faster to do an ultrasound. It gives you much more information.
Thank you. Generally speaking, I completely agree with you. Even if, but you already state that there are some contexts probably where chest X-ray still may play a role. For example, Cosmin, when I worked in cardiac surgery ICU concerning, like Silvia already mentioned, the drainage, probably this is something that may play a role. What is your opinion, Cosmin?
Yeah, absolutely. So doing a chest X-ray, I find it useful just to check if your drains are where they're supposed to be, where they're supposed to be placed. But other than this, I always do an ultrasound. I can do 5 ultrasounds within 2 hours. I can't do 5 chest X-rays. And I think from a functional point of view, the ultrasound is far more sensitive and specific. Whenever you're doing, just like Sylvia said, when you're doing a recruitment maneuver, I'm not gonna monitor that using a chest X-ray, but I'm gonna use an ultrasound. And in cardiac surgery, because patients so much often they have subxiphoid drains, and we can't do a subcostal view, and they have other TTE views impossible to look at, we do a TE, and I have a single evaluation for both the lungs and the heart, acknowledging that there is no standardization of lung ultrasound by TE, but anyway, looking at things like a recruitment maneuver and what the recruitment maneuver does to the RV and to the RV to LV interaction, that's very, very, very useful to have at the bedside. I can't do that with a chest X-ray.
Also, fantastic insight. So the application of TE for the assessment of lung ultrasound. There will be another session, another speech on that point, and for sure, during, for example, if for any reason, I don't know why, you need or you want to perform a recruitment maneuver during a cardiac surgery or in the operating room, and you already have the TEE, you can assess also the lung, including, but I don't know if I'm right, that if you apply a 3D application, you have the chance to assess the lung parenchyma, not only artifacts. I am right?
I've never used it, so I've never used
because,
it.
There are some papers concerning, for example, the recruitment maneuvers and the assessment of pleural effusion. And moving forward, another topic, we talk about a lot of application, but we talk about lung ultrasound, the lung. We talk about the muscles. The diaphragm and the muscles. So the question is, I'm a little bit confused. The lung is enough, or I have to try to put all together? So the strength and evaluation of the muscles, inspiratory, expiratory, and diaphragmatic, and the lung, or the lung is enough? Silvia.
I have a conflict of interest. Of course, it really depends on the question you want to answer to, because there are very complex clinical issues, as